Good evening. Thank you for joining us on this Michigan winter evening. I'm Early Washington. I'm the Dean of the College of Health and Human Services. It is my pleasure to welcome you to the Bill Burian University Community Lecture Series featuring Dr. Brian Gibbs, a public health practitioner, occupational therapist, health disparity expert, and assistant professor in the Department of General Internal Medicine at Johns Hopkins School of Medicine. The Bill Burian University Community Lecture Series honors the memory of Dr. Bill Burian, the first Dean of the College of Health and Human Services at WMU. Dr. Burian was known as a person of great foresight and vision. He was a distinguished scholar, researcher, educator, and community service activist who was well known in many circles and held many leadership roles at the national, state, and local levels. The Bill Burian Endowed Lecture Series focuses on community and educational issues in the health and human services from a problem-solving perspective. It brings together students, faculty, community professionals, service providers, and citizens to interact with leaders in the field. Dr. Burian would be pleased to see all of you here this evening with our distinguished speaker to examine health disparities and to find a way to address and reduce these inequities. Dr. Burian would also be pleased, as I, that this analysis, interaction, and problem solving will continue tomorrow with the conference, Diversity and Inclusion, Preparing Ourselves to Advance Health Equity, hosted by the College of Health and Human Services Committee on Diversity and Inclusion. And I know that many of you attending this evening are also planning to be a part of that conference, and that Dr. Gibbs will continue his participation with a keynote address tomorrow morning. The lecture and conference together are expressions of the values of the college, the university, and Dr. Burian. We are committed to being a community of leaders that embraces, respects, and advocates for human diversity, inclusion, and social justice in its education, research, and service programs. Preparing people for leadership roles who understand their professional tasks in a context that embraces the holism, the beauty, and the challenges of life. Fostering interprofessional education within the college, the university, and with professional communities. Contributing to the quality of health and human services in West Michigan, the state, and the nation through instructional programs, research, and community services, and encouraging a comprehensive service system that is responsible to all citizens. Again, welcome to all of you. I trust you'll find this evening interesting and valuable, and I invite you to a reception in the lobby after the lecture. I also welcome Dr. Gibbs, who will now be officially introduced by Dr. Ben Atchison, Interim Chair of the Occupational Therapy Department, who I understand is a former professor of Dr. Gibbs, a current colleague and friend, Dr. Atchison.
Thank you, Dean Washington. Those of us who have the distinct privilege of teaching students in higher education, hold close to our hearts and minds those exceptional students who come through our classrooms on their way to their professional careers. The experience of knowing and being with so many unforgettable men and women is a uniquely enriching part of my life. And I know many of you here this evening who are teachers and educators can readily share this feeling with me. In the winter semester of 1978, I was a brand new instructor at Eastern Michigan University. I thought I knew quite a lot. I'd had 2 years of experience, and I thought I had to come and share everything I knew as a college professor. And I was very excited about my new position. Now, in occupational therapy, being a very small percentage of men, I readily bonded with the guys that came into occupational therapy, like me, who appreciated the many opportunities that exist in our profession, and not always sure why it's so really gender specific. Among those guys was a young man who was quiet, shy, soft-spoken, and very intelligent, yet found himself struggling with a course in our program that so many other students actually struggled with as well. But for this person, the struggle became a potential barrier to proceeding in the program. But in his drive to succeed, in spite of significant discouraging forces, he graduated from EMU in 1981 and began a career. And what a career he's had. Starting with a professional life devoted to the most vulnerable populations, our Bill Burian lecturer began his work as an occupational therapist, working with victims of youth violence in California, while at the same time earning a master's degree in public administration from California State University in 1985. This was followed by his appointment as Director of Minority Affairs for the American Occupational Therapy Association, where he led a series of efforts to bring awareness of the need for cultural competence as an integral part of being a competent occupational therapist. Realizing an interest in public health research, he was selected for a competitive fellowship at Brandeis University, where he earned his doctoral degree with a strong interest in health diversity, becoming the first African American male in occupational therapy to earn a doctoral degree. Following his degree work at Brandeis, our keynote speaker began his postdoctoral work at the Harvard School of Public Health, where he spent 10 years as the founder and director of the program to eliminate health disparities. He was a senior research scientist within the Department of Health Policy and Management. He was a principal investigator for Breaking It Down, Our Health, Our Way, a pilot initiative funded by the Education Network to advance cancer clinical trials. He also served as Center Director, Community Outreach and Intervention Core Director, and co-investigator of 2 consecutive NIH National Center grants for minority health and health disparities. He was a member of the Massachusetts Racial and Ethnic Health Disparities Council, the Attorney General Task Force on Community Benefits, and the National Association of State Offices of Minority Health. He's also co-author of the Commonwealth Fund State Policy Agenda to Eliminate Health Disparities. In addition, our Burian lecturer co-founded and directed the Cherishing Our Hearts and Souls, a 9-year-old community-based coalition in Roxbury, Massachusetts, representing over 200 organizations and individuals. The coalition was established to educate communities, providers, and policymakers about the intersections of racism and other social and environmental determinants of health. Most recently, as Associate Dean for Diversity and Cultural Competence at Johns Hopkins School of Medicine, he was responsible for all matters of cultural diversity, including faculty, staff, and fellowship recruitment, retention, and promotion, as well as improving the institutional cultural climate, community perception, and patient satisfaction in Johns Hopkins Medicine. He created diversity initiatives that were designed to be sustainable and adaptable, requiring involvement from all levels of the organization, from housekeeping staff to executive leadership. This evening, He comes to share his knowledge, his experience, and his heart about issues of diversity and health disparity. This shy, quiet, unassuming student of mine, who I always believed would shine bright in whatever he did, has done so immensely. And here I am, with the greatest honor I could have, to introduce a man I truly admire and love, Dr. Burian Gibbs.
Good evening. Good evening. Thank you, Ben. And all he just said, the most important thing was, I was his student. And for that, that is indeed an honor. To Dr. Washington, Dean of the College of Health and Human Services, the College of Health and Human Services faculty, administration, staff, students, and supporters from across the university, I greet you this evening with humility and excitement. I'd like to express my sincerest gratitude to Dr. Yvette Hyder and members of the Committee on Diversity and Inclusion for their invitation to serve as lecturer at this distinguished event. I'd also like to thank supporters of the Racial Healing Grant for their financial contributions in support of tonight's and tomorrow's activities. And finally, acknowledge and thank Patricia Patinga for her logistical coordination and support. For those of you who stand on the front line helping to improve health care, drive awareness of the needs of Kalamazoo County residents while remaining sensitive to their many social, economic, and political barriers, I thank you for your work and also for your presence here tonight. The region you serve across the state is huge, and so are your hearts. You are the ones who are making a tremendous difference. You are the ones who truly put care after health. In researching Dr. Burian, I discovered someone who had accomplished a great deal in a relatively short lifespan. He was an unmatched ambassador of the allied health profession, someone who tenaciously connected his scholarship, research, teaching brilliance to his vision to transform healthcare while elevating the health of the most vulnerable communities. I'm certain that, like most visionaries, Dr. Burian was someone who had the answers before his colleagues and associates even knew what the question would be. I also discovered a quote from Maya Angelou that I believe Dr. Burian, had he been with us today, would want me to convey to you. When I thought about all the people that you all go out and touch because of the work that you do, because of the vision that you have, because of the passion and the understanding that if not you, then who would do it? I want to thank you in their names. Those faces you'll never see, the names you'll never hear, they thank you because of your commitment to the idea of equity in medical care for everyone. And then I would envision a challenge that all visionaries impel, and that is to see things before they actually happen. And he wanted us to move beyond disparities, because that's a word that puts the onus on those individuals who are the most encumbered. He would want us to see a different image, one that was more equitable, one that was more hopeful, one that spoke of opportunity. more resolve. And so I am very privileged to stand and present in honor of such a great man. I'd like to share some brief impressions about a movie called The Life of Pi. I'd like to see the hands of those who've seen the movie. It's great. Pardon me?
That was a joke.
I need jokes. For those of you who have not seen it, I won't spoil it for you. But I encourage you to see it soon. Put it on top of your list of must-see movies. It's a movie that's made in 3D, and it has the most beautiful and striking visual effects. It really draws you in. The movie is about a young man named Pi Patel, a precocious young man whose parents own a zoo in India. They decide to sell the zoo and transport the animals to Canada for sale. While crossing the Pacific Ocean, there's a disaster at sea, and Pi is hurled into an epic journey of adventure and discovery with another survivor, a fearsome Bengal tiger, whose name, by the way, was Richard Parker. And together they survive in a lifeboat for 227 days. For me, this movie captures two elegant dimensions of diversity and faith. An ability to see what you believe versus believing what you see. That is the essence of my relationship with Dr. Ben Atchison, who, along with another member of the occupational therapy faculty, Sherry Sells folks, significantly altered my life course. You see, when Ben and I first came together in his classroom, neither of us had any idea, that we would end up sharing a priceless journey together, similar to Pi and Richard Parker. In the classroom, Ben was an enthusiastic educator. He was meek, he was humble, an ever-present teacher, student advocate. And as one of his students, and again, I emphasize his students, Ben encouraged me to own up to my poor academic performance in his class. His asset-based approach helped me realize that my failings did not have to define me as a poor student, as some of those weeding out courses will often do. Instead, he helped me believe in myself and helped me discover my true potential to learn. Potential that he could see so easily, in spite of the unfriendly and non-inclusive student and teaching environment that I was experiencing. Advancing along my career path, Ben became an unselfish mentor, colleague, and friend whose advice and support always came with gushing pride and gratitude. Ben, thank you for seeing in me what I could not see in myself. You helped me move away from that someone who was fearing failure in the classroom towards that someone who would eventually accept that he had unlimited learning potential. If I had to sum it up in one word, the role you've played in my life, I'd call you Godfather. Please, let's share. Staying with this theme, the life of Pi, and an ability to see what I believe versus believing what I see. As a healthcare and public health practitioner, administrator, researcher, and having spent 30-plus years looking at health and healthcare-related issues, I am convinced that we can and must do better, and we must do more as a society to improve health where health is impacted the most, and that is in our communities. I'm going to provide an overview of health disparities. I'm going to talk briefly about solutions, and then hopefully we'll have some time for questions and answers. Health inequalities are the differences in health status or in the distribution of health determinants between different population groups. So it's that differential that may be based on income that impacts health, or where you live, or geography that impacts health. What kind of income you have will determine what kind of insurance you have, or what employment you have may be impacted by the kind of education opportunities that you've had, which may be impacted based on where you grew up and what kind of income your family had exposed to. And so there are all these different linkages before we can really qualify the determinants of health. And even furthermore, ferret out the difference between what having access to health care really means. Because it's not just access to health care that's going to improve health. And oftentimes when we think about the amount of money that is spent towards health care, and it doesn't change the slope of health for the most vulnerable, somewhere along the way, it's not just health care, it's really about our values. So it's really important to not just delve into the notion of health disparities as if they started yesterday. As a surrogate, I use this slide to help explain, but using the African American's history, relating that history to health, the African American experience is a surrogate for any other minority group coming to America. What we have as an experience around health is in 1619 through 1865, or a period of 246 years. That represents 63% of the Africans' experience since coming to, being enslaved in, partially freed, and freed with partial rights in America. 63% was spent as chattel slavery. That 63% represents from 1619 to 2013. And so we begin the health experience with a very deep hole, because the health care that was provided during this period was the kind of care that you would provide to pigs, to cows, to chickens, things that would be about produce or a product for an enslaved people. In 1865 through 1965, we have a period that reflects Emancipation Proclamation, where blacks, slaves, were freed, but with no rights, no access to homes, no access to health care, no access to education, no access to employment. And this 100-year period reflects yet again an elongation of the health gap, because you're presumably free, but you have access to very little. And that represents 25% more, or a total of nearly 90% of the African Americans' experience since coming to America. Nearly 90% is comprised of this very, very deep hole of health inequality and health care disparities. And then from, my numbers are off, so I apologize because I'm looking at this and that doesn't work. From 1965 to 2013, it represents a little over 12%. A little over 12%. With voting rights, Medicare, Medicaid, access for the poor to receive care, comparable care, presumably comparable care, in hospitals that could no longer segregate based on race and ability to pay. Because up until 1965, looking back over that, say, 80% of the Africans' experience, black physicians weren't trained in white medical schools. Black physicians weren't able to admit their patients to white hospitals. Where patients were admitted, they weren't in the same wing as white patients. The technology that they had access to was inconsistent with what was available to everyone. And so even in the delivery of health care, there is this inferior system. And so if we were to fast forward, and I embellish now what I'm going to talk about a little bit more in the next few slides, if you can appreciate the slow progression of change, it is not just systems, it is not just our society that's slow to change, it's really people. And that's really an indication of what's reflected within their hearts. And so a sub-theme really involves being able to see what you believe versus seeing what you believe. Because at the end of the day, no matter what else I say, that's the point that I want you to take home. Because that's what's going to challenge you to think critically about the same images that you see in poor communities. It's going to challenge you to believe differently. To believe differently. When you have patients who come in to receive your nursing care or your therapeutic interventions, and they don't seem to be adhering to the treatment protocol, and you document non-compliant, think critically about how you frame that particular patient based on your educated values. So when we frame health disparities, we have to appreciate the context in which they can come about. The contributors that include the biological factors, the environmental factors, socioeconomic, the cultural dimensions that exist in our society, the psychosocial stress factors that occur in intermediary kinds of or interpersonal interactions, the health risk behaviors that we all experience through the age span, the access that we have to health care, and the quality of that health care experience. When we think about, as I said, the amount of revenue generated or the investment of dollars for health care, it is so hugely disproportionate to what really promotes health, what really impacts health. Health care is only 10% of the wheel. 20% is genetics. Another 20% is environment. And the rest is 50% that involves behavior. Health outcomes among U.S. minorities. There's 84,000 deaths that occur in the U.S. each year due to the health care gap. Blacks, Hispanics, Asian Americans are more likely to be uninsured, not have a regular medical doctor, and report having difficulty paying for health care. Minorities get sicker, younger, have more severe illnesses, and die earlier in comparison to whites. African Americans have 3 times as much high blood pressure, diabetes, cancer, and heart disease in comparison to whites. Here in Kalamazoo, babies born to black mothers are 3.7 times more likely to die before 1 year of age in comparison to white babies born to white mothers. And the rate of overweight or obesity is higher among blacks here than whites. Another way to frame this is, in a 9-year period, we have data collected by many individuals, including our former Surgeon General, that looked at a 9-year window between 1991 and 2000. In this time frame, 900,000 African Americans died because they didn't receive comparable care for the same kinds of diseases or illnesses as white Americans received in the same period of time for the same conditions. That translates into about 280 individuals every day. And so let's go out to California. And if you heard reports that every day planes taking off from LAX, there was a plane crash and 280 individuals died every day, would that be concerning for you here in Kalamazoo? Or let's move a little closer. Let's say Albuquerque, New Mexico. Planes taking off every day, 280 individuals dying in a plane crash every day. Here in Kalamazoo, would that affect you? Did you think about it? Okay, let's go to Detroit. Detroit Metro. Planes every day. There's a plane crash. 280 people died every day. In Kalamazoo, would that bother you? Ben picked me up from this very beautiful, brand new airport here in Kalamazoo. If 280 individuals died every day from a plane crash, would that be concerning to you? Let's say if maybe your brother, your mother, your sister, your father was one of the 280 that died, and that these plane crashes were occurring every day. Would that sort of intensify your sense of urgency? How close does it have to come to hit home before that urgency or that agency kicks in? Because America allows that to occur. That's happening every day on America's watch, and there's no urgency. When you're poor, your chances of dying prematurely are 3 times higher than if you have incomes over $100,000. That's pretty straightforward. The poverty rate for non-Hispanic whites and for blacks in Kalamazoo County is 13% and 40% respectively. This compares to only 10% for whites and 31% for blacks statewide. In the city of Kalamazoo, 30% white residents are poor compared to 52% black residents. The poverty rate for non-Hispanic white and black children in Kalamazoo County is 8% and 48% respectively. In the city of Kalamazoo, 15% of white children versus 61% of black children are poor. When you're poor, you have multiple disadvantages. Your educational opportunities in childhood and adolescence are significantly compromised for a lot of different reasons. Sometimes it's just a matter of not having enough light at home to study. Sometimes it's just too much noise at home to study. Sometimes it's just too much going on outside in the community that creates worry and stress, and so you can't sleep, which impacts your performance in the classroom. You have insecure employment and or unemployment, working 6 or 7, 3 or 4 jobs. You got to catch the bus. It's hard to keep a job, a steady income. You're stuck in hazardous dead-end jobs because they're the ones that you can get, but you're not necessarily receiving any benefits. You're living in poor housing. You're living in neighborhoods with fewer resources. You're trying to raise a family in very difficult circumstances. You're living on an inadequate pension. You eat poorly and you forego exercise and you skip your medications. And the best thing that my nurse or my therapist or my physician assistant can document is patient is non-compliant because of the lack of understanding about and an inability to communicate around issues that are very, very significant, in fact, much more significant than health. When you have high socioeconomic status, you live in better neighborhoods, you occupy healthier home environments, you have lower exposure to crime and other stressors, you access to better education and employment opportunities, you access better physical facilities, you access higher quality medical services, you have better nutrition, and you have greater control over your life. So health can be affected not only by your socioeconomic status currently, but by exposure to these social and economic determinants over one's life course. Hence, the pathway to premature death or compromised commitment to wellness or going to the doctor late and or a historical kind of experience where you just don't trust the healthcare system because the healthcare system hasn't figured out how to really connect and provide culturally competent care with a patient population that is only being responded to based on what you see. So some of the solutions that I want to highlight very briefly have to do with the governmental, institutional policies and practices, the cultural competence that can and should occur in healthcare settings, collaborative partnerships that I'll talk a lot more about tomorrow for research and practice. In terms of policies, what we need are universal policies to improve health, but we also need strong leadership, and we need sustained commitment from state and policymakers. We need to connect universal policies and practices with very, very local focused interventions. We need to conduct reliable data and data collection and appropriate data analysis. And unless we're really able to look at numbers and see diverse dimensions of what those numbers may convey, such as looks like patients aren't compliant versus patients aren't receiving comparable care, versus our practitioners have not figured out how to really make a connection with our patient population that seems to be lagging in terms of their health care. They're having a level of frustration that shows up when that patient who has missed 2 or 3 appointments canceled because of many other things that were a priority. That patient finally shows up and there's this very, very strong attitude and judgment about this person's life. That doesn't inspire health. That doesn't inspire openness. That doesn't inspire trust. We need to involve all health system stakeholders to make a difference in eliminating disparities. We want to support research to identify the differences in access. We want to be able to understand what are these perceptions our clients are having towards us. And we want to be able to understand better what our reactions are to our patients. We want to be able to understand, one, what my limitations are in meeting the needs of certain patients. I want to be able to survey and get a better understanding of what it feels like to be incompetent, although it's not framed that way. Let's just say it's not incompetent, it's just an inability or discomfort in connecting with certain patients from different groups. It's a hard thing to say. It's a hard thing for smart people to say. And yet, it's real. If you haven't lived the experience, how are you going to know? If you're not open to having the patient teach you, how are you going to learn? And it's clear for very smart people, while they may be poor, they're not stupid. They're very critical and very discerning. And they see that you don't care and you don't care to learn. And they're not going to take the time and care enough to teach you. And so all you have is a whole lot of dissonance and disconnect in that interaction. And at the end of the day, it's the patient's fault because you have the power. And so as healthcare providers in all the different dimensions, we need to increase our knowledge regarding health disparity populations. We need to improve our cultural awareness and our attitudes regarding the care of these patients. We need to really examine our pipeline for where STEM education, science, technology, engineering, and math gets introduced into the elementary school all the way to high schools. And sometimes we do really good projects and programs on weekends, and we fail to understand that teachers don't really know how to teach science, technology, engineering, and math in the manner in which it's being applied at this level, or at a graduate level, or at a PhD level, or where it will take us into the future, when they're struggling to just keep students seated and keep their attention span focused. And so we have to be able to help teachers teach. We have to be prepared to receive these students in the classroom, the same classroom that I entered, that Ben reflected on, that I reflected on, that wasn't ready to receive me. The only reason it wasn't ready to receive me was because of the way I looked. Had I been white, blonde, and blue-eyed, even tall, there would have been a different kind of receptivity. And no matter what my critical thinking was, my judgment, and I got a pass. And you know what? I would take advantage of that pass. Whereas looking like me, I got the barriers. No difference, just the physical. And so it's incumbent upon you all as students, as practitioners, as advocates, stakeholders, university representatives, to begin to really think about what it means to have students of color in your classroom. One, you got to think about, why is that important? Because when you look in your classroom and you don't see much representation, does that look like the United States? And you've got to think critically, and then you got to speak strategically about these kinds of things. You become the agent of change when you can reflect. Something is wrong. We can do better. If not this person who's going to do it, then I need to step up and I need to figure it out. Oh, and by the way, individuals of color who are in the classroom hesitant about speaking up because they become a target. You cannot put the onus on them to make the change. You cannot put the onus on them to be all about the change. If they're the one or two or three, then everybody's cool. This is good. And nobody says anything because they're here, so on and so forth. That's not welcoming. That's not inclusive. That's tolerance. That's as good as it gets. If you were in a job where your employees or your employer and your coworkers were only tolerant of you, and you realized that you were different, and everyone else around you, they were just tolerant of you, wouldn't that get tiring? Nobody says anything. It's just the way it is. It's the environment. But would you not get tired? Would that not become fatiguing? If you were short in a wheelchair without an arm, and everyone was polite, it couldn't figure out how to engage, it was awkward, it wasn't race, but it's now physical. It's different. It's different. It's different. It's different. It's different. And that's all it is. It's just different. And we are comfortable with saying. And that's where we have to get out of ourselves and become someone different. Because unless we do that, this chasm that we're talking about relative to health disparities will only be perpetuated. Because, you know, the planes that are crashing in Los Angeles, that's Los Angeles. Oh, I'm sorry, the ones in Albuquerque, yeah, that's Albuquerque. Oh, I'm sorry, Detroit? Oh, yeah, that's just Detroit. Oh, well, you know, if it happened here, yeah, it happened in Kalamazoo at the airport. Oh, okay, well, it's the airport. Thank God it didn't fall on my house. Oh, man. Whew. How much death, how much stress are we going to be tolerant of before we realize that that's really poor health? That's what's driving health disparities. So we have to look at this issue of racism, classism, sexism, and we have to appreciate the effects on health. We have to figure out how to use the research process to mobilize communities that can advocate for change. We, engaging community, have to figure out how to listen. Listen. Listen to community and hear what community is saying. Don't be so busy about taking your notes, filling out your sheets and forms and turning them in and getting your compensation and documentation all completed in a pristine manner because you've got JCO who's monitoring all these different things, and the patient is just sort of a secondary. We have to recognize privilege. We have to recognize privilege that is in operation. I don't care whether you are a white person engaged in doing good in minority communities. I don't care if you're a person of color doing great things in communities of color. I have had to recognize that with my education, with the way in which I'm able to dress, the way in which I can enunciate, speak, and present in a very poised way, that's a privilege. And when I'm in communities that have had less, I have to recognize my privileges. And I have to not speak, but really listen. I have to turn off my censors because the words that were chosen, they just didn't add up to the way in which I would have said that. I'm distracted. I'm not really listening. I'm not really hearing what community is saying, no matter how the community is saying it. So I know oppositional thinking is here. That's what academe is all about. I know critical thinking is here because that's what academe is all about. I know we want to push the envelope because that's what we do when we come to learn. And we want to advance science. We want to advance knowledge. We want to improve upon those who taught us. We want to leverage those opportunities, and we want to do great things in the world. We want to change. So I know that energy is here. I am totally convinced. And it's good energy. It is good energy. And so we have to think critically about this box that we're in, and we have to learn how to work outside of the box. We have to disseminate critical information, and we have to use social protest and social embarrassment when necessary. As a nation, I know we can do it because in 1963, it wasn't just about voting rights. Again, as I said earlier, it was about Medicaid, Medicare, access to segregated hospitals, which in receipt of Medicare, Medicaid funding could no longer segregate patients. So now we have improvements in all areas of the things that we measure as health determinants today, improving with just a little bit more access. It was a push through this movement that occurred. The byproduct of the civil rights movement was better health care. That was huge, but it took a whole nation, not just African Americans, but a whole nation to stand up, to speak up, to march, to make that difference. And so I know it's here. And it's 40 years later. It's still here. 40 years since Dr. King's I Have a Dream speech. The collective will of our nation, in spite of contentious and mean-spirited politics, came together yet again to elect its first non-white male president, Barack Obama, who during his first term in office led a sea change movement to bring about universal health care and an effort to focus on eliminating health disparities, allowing health care for all, and not penalizing those who have pre-existing conditions like many people of color do. So the strategy is clear. Where there is a will, there is a way. That will is the question. So what can each of us do? What can each of us do? Here's Mr. Parker again. Mr. Parker and Pie. Believe the unbelievable. However, before doing so, we as individuals or as an institution and society at large must do some significant self-reflection. Because we but mirror the world. All the tendencies present in the outer world are to be found in the world of our body. If we could change ourselves, the tendencies in the world would also change. As a man changes his own nature, so does the attitude of the world change towards him. And that's by Mahatma Gandhi. And therefore, each of you, like Pye, Richard Parker, Ben Atchison, my godfather, must begin to look differently at the poverty and poor health status of African Americans and other minority groups living in communities around you. You must see beyond skin color and see the change and be the change. Change your beliefs and then begin to see what you believe. Thank you.